Radium-223 is one of the 6 life-prolonging therapies. It has a unique mechanism of action because so far is the only bone target therapy who has shown to improve survival. And the study that led to its approval is called the ALSYNCA trial, where patients with metastatic castration-resistant prostate cancer, pre or post docetaxel, almost half and half, were pre and post chemotherapy, received radium-223, and basically the group of patients who were treated with this therapy actually had a prolonged overall survival compared to the group of patients who did not receive this treatment. So as we're saying, radium-223 is a very special agent with a very specific mechanism of action. So basically, it's an alpha emitter and is a calcium mimetic. So it acts in areas of increased uptake in the bones. So when we think of the ideal setting for radium-223, we would argue that it's probably pre-chemotherapy post the first androgen receptor target therapy. And the reason behind it is that we have data showing that patients who receive 5 or 6 treatment administrations do better than those who receive up to 4. And on the other hand, you know that patients who do not have visual disease nor lymph nodes larger than 3 centimeters are those who are going to benefit from radium-223. So in other words, if you think of the setting early on where you will have bone-mainly disease, you have a good performance status, and at the same time, you are more likely to receive the 6 doses of radium-223, is probably the sweet spot for this therapy. It is interesting how the developing of radium-223 has happened in the last few years, right? Because the initial approval was based on radium-223 compared with placebo in a 2-to-1 in the ALSYNCA study. But in real life, because it's a bone target agent, a lot of us start combining it with oral androgen therapies such as abiraterone and enzalutamide. And so it was not a surprise that we saw those trials being conducted both with enzalutamide and abiraterone. Now, we had recent data from the trial called ERA-223 showing us that the combination of radium-223 and abiraterone is not safe, basically because we saw an incremental risk of fractures and death. And so the approval was changed, and basically the combination of radium-223 and abiraterone is now not recommended. So far, the phase 2 trial exploring the combination of radium-223 with enzalutamide has shown to be safe. So no negative signal has been demonstrated, and the phase 3 trial is ongoing. I'm excited to see the results of that study because it will be important for us to know whether the combination of bone target agent such as radium-223 and androgen receptor target therapy such as enzalutamide or any other anti-androgen can improve outcomes compared with radium or enza alone. I think that question needs to be answered, and fortunately we'll know the answer once the study reads out. After radium-223 has been approved, we had a number of expanded access programs, and the data has been published from those programs showing that patients who received 5 or 6 cycles of radium-223 do better than patients who receive up to 4. At the same time, patients who have better performance status also do better than patients with not so good performance status. So indirectly, you can say that if you're gonna think of radium-223 as one of the good treatment option for your patient, you probably want to offer him sooner rather than later because you're less likely to have bone-only disease. You're more likely to have not so good performance status, and also you're probably less likely to offer the full 6 cycles of therapy.